Good morning to one and all. This is in continuation with our e-content series. I am Dr. Vishwaja from Department of General Pathology. Today's topic of discussion will be on aplastic anemia. Now coming to the definition of aplastic anemia is also defined as pancytopenia. It is a condition wherein there is a combination of anemia, leukopenia, and thrombocytopenia resulting in a diseased individual due to aplasia of the bone marrow. Now, coming to the etiology of aplastic anemia. Aplastic anemia can arise due to multiple causes. To start with, genetic causes play a very important role. This is followed by probably autosomal recessive inheritance, which can give rise to the onset of the disease. The other acquired causes for aplastic anemia include drugs, followed by toxic chemicals, infections, and also certain miscellaneous agents such as autoimmune diseases and exposure to therapeutic X-rays. Coming to the classification of aplastic anemia, they are primarily classified as aplastic anemia of primary etiology and secondary aplastic anemia. Now coming to primary aplastic anemia, this classification is subdivided into Fanconi's anemia, which is of autosomal recessive inheritance, and it is also associated with certain congenital anomalies such as skeletal and renal abnormalities, and also associated with mental retardation. Now coming to the other subsect of aplastic anemia, primary type, the immune type of aplastic anemia is probably associated with the suppression of the hematopoietic stem cells due to certain immunological mechanisms. To name a few, autoimmune diseases are primary causes for the onset of immune type of aplastic anemia. Now coming to the other subsect of aplastic anemia, that is the secondary type. Now secondary type of aplastic anemia is comparatively more common than the primary type, and it is associated with variety of causes. To name a few, the most important being the drugs. Cytotoxic drugs, which are frequently prone to suppress the bone marrow, plays a very important etiological agent. To name a few drugs, methotrexate, followed by mitotic inhibitors such as daunorubicin, alkylating agents such as busulfan, nitrosoureas, and anthracyclines play a very important role in attributing to the onset of secondary type of aplastic anemia. Now coming to the other causes for the onset of the disease, drugs like sulfa, oxafenobutazone, chlorpromazine all play an important role in also initiating the onset of the disease. Now coming to the toxic chemicals, which also play a very important role in the onset of the disease. Examples: usage of industrial, domestic agents such as insecticides, pesticides, arsenics, benzene derivatives, all attribute to the development of the disease. The next important cause is infections, especially viral infections can lead to aplastic anemia. Examples: Epstein-Barr virus, hepatitis, HIV diseases, all attribute to the onset of the aplastic disease. Now coming to the miscellaneous causes, autoimmune diseases like systemic lupus erythematosus, also known as SLEs, and frequent therapeutic exposures to X-rays and also usage of broad spectrum antibiotics can all prelude to the onset of aplastic anemia. Now, coming to the clinical features of aplastic anemia, the onset of the disease can occur at any age group and it is usually insidious in onset. The clinical features and manifestations of the disease include number one, anemia, and usually the symptoms associated with anemia include mild progressive weakness and fatigue. Now, this is followed by onset of infections. Now, infections especially are a very common presentation, especially infections of oral cavity and the throat. Now, coming to the other symptoms and signs of aplastic anemia, this includes hemorrhagic episodes which could lead to thrombocytopenia. Now, hemorrhage particularly arising on the skin, nostrils, gums, vagina, bowels, and also occasionally associated from the CNS, central nervous system, and retina, all include as manifestations of the disease. Now, coming to the other clinical features, there could be enlargement of liver, spleen, and lymph nodes, which are very mild in onset. Now, coming to the laboratory findings of aplastic anemia, the most important diagnostic features of the disease include number one, hemoglobin levels, which are moderately reduced, and patient presence with a blood picture of normocytic normochromic anemia. Occasionally macrocytosis may be present. The next investigation is the reticulocyte count, which could be moderately reduced. Now, the next investigation for diagnosing the disease includes WBC count, wherein the patient presents with leukopenia, the absolute granulocyte count is particularly low, and sometimes the patients can present with a relative lymphocytosis, and also the alkaline phosphatase score could be increased in the disease. Now, the next investigation is the platelets. The platelets are also moderately reduced, and the next confirmatory investigation for the disease includes the bone marrow examination. A bone marrow aspirate could yield a dry tap. A trephine biopsy is always recommended, which reveals a patchy areas of cellularity in the disease, which could be sometimes markedly hypocellular depending on the extent of the disease. And these areas of aplasia are replaced with the adipose or the fat tissues. So we could appreciate a simultaneous suppression of the myeloid series, megakaryocytic series, and erythroid series. All these elements ultimately confirming the disease to be of aplasia of the bone marrow, and thus we are able to diagnose the disease. Coming to the treatment, the principles of treatment for aplastic anemia include number one, identification of the possible etiological cause. Now, the etiological element has to be eradicated. This is followed by supportive care, which includes frequent blood transfusions, supplementation with platelet concentrates, and also prevention of infections. Now, coming to the specific treatment of the disease, number one, to start with, patients are put on marrow stimulating agents, especially androgens, which are administered orally. This is followed by immunosuppressive therapy, which was frequently done using the anti-thymocyte globulin and anti-lymphocyte serum. Now, this has been proved to have a major success rate, and this is followed by supplementation of the patient with high doses of steroids, especially glucocorticoids and cyclosporin. Now, all these yield good results for the disease and reversal of the bone marrow aplasia. Now, this is followed by splenectomy in cases where the spleen is markedly increased. Elsewhere, bone marrow transplantation is also recommended in a patient who has been having the disease for a prolonged period and who is under 40 years of age group, where HLA and mixed culture matching of the donors can be done, and bone marrow transplantation is particularly done for cases of acute myeloid leukemia and acute lymphoblastic leukemia, followed by thalassemia major. All these are indications for the bone marrow transplantation, which is always associated with aplastic anemia. Now, coming to the complications of bone marrow transplantation. Number one, severe infections followed by graft versus host reaction. So, graft rejection and graft versus host disease are some of the most important complications encountered during bone marrow transplantation for aplastic anemia. Now, coming to the prognosis of the disease, this disease is a very serious disorder. If not treated within the stipulated time, death and mortality could be inevitable. So, within a span of 6 to 12 months, the patients have to be completely treated. Otherwise, death usually occurs due to bleeding episodes or due to intercurrent infections which the patients encounter. Thank you. So, thank you. With this, we conclude the e-content series and we will meet in the next e-content series topics.